I'm Manish Sacheti, CFO of Ziqitza Health Care Limited, based in Bombay. So, emergency medical ambulances would be a network of ambulances spread across the geography in concern. What happens is you need to get the ambulances to the patient or the victim as soon as possible, and they can't be located in a specific location. They need to be spread across. Second thing is that they should be easily accessible and the public should know how and where to contact them. So just to give you an example, if you had an emergency and you called the hospitals up, they would only send the ambulances from that particular hospital, and that might not, and that particular ambulance might be out at that particular point. Whereas in an emergency medical service, the ambulances are spread across the city. As soon as you call the centralized call center, so that number has to be known also to the public, the nearest ambulance would be dispatched to that particular location, regardless of wherever he is in the city. There will be an ambulance close by. The difference between the other services where you have ambulances scattered across the city is, one, you don't know how to reach them out. You have to look at the yellow pages, call different ambulance services up, and depending on your luck, you would probably get them on the first attempt or on the 9th attempt. Whereas if you look at how things work in the US, 911, people are taught just to remember 911. Once they call 911, the location is taken and the ambulance is dispatched within seconds or within a minute or two. So that is the basic crux of the emergency medical ambulance service. One, having a centralized call center which has a centralized number known to the public. And secondly, having ambulances spread across the city rather than sitting in one place. So Ziqitza, you might also want to know how the name came up also. So Ziqitza is a combination of two Sanskrit words, Chikitsa, which is medical healing, and Jigyasa, which is quest for knowledge. A combination of two was used to coin Ziqitza. So Ziqitza had got into this business around 2004 with the intention of filling the void in the ambulance space which was there in India. So when we got into the ambulance space, if you had to call an ambulance up, before the ambulance would be dispatched, you would have actually had to go to the ambulance office and pay the money, and post receiving the money, the ambulance would be dispatched. So we all got together, 4 or 5 friends got together and decided to get into this area and see how we could help and change the ecosystem here. We started in 2004 with 1 ambulance, scaled it up to 10 ambulances by 2005, had a soft launch with a centralized call center in Bombay with 10 ambulances. We started the service under the number 1298, where anyone in the city of Bombay could call us from the mobile, from the landline, and they just had to dial 1298, and the ambulance would be dispatched based on the closest available ambulance. We scaled this up from 10 to 60, 70 by 2010. And in between, what had happened was, so all these ambulances were operated by us. These were all owned by us and operated by us. And the payment mode was, you use the ambulance, you pay. There was no need to become a member, but just like a taxi service, you use the ambulance and you pay for the ambulance. So this was one difference from before, where earlier you had to pay first. Now in this case, you pay after you use the service. The other question which came up at this time was, like, a lot of the needy would not have the money to pay for the ambulance. So we came up with this cross-subsidy model where we charged slightly more to the rich and subsidized or even free service to the poor. The question which we had to answer was, how do we determine based on a person's clothes whether he's rich or poor? So we did the best possible thing that came to our mind was, depending on the locality the person calls the ambulance from, and depending on which hospital the ambulance goes to, we take a call on whether he is rich or poor. We would, but in spite of this factor, if the person says that he cannot afford to pay, then we look at the circumstances and take a call. So we've had a case, I mean, I'm sorry, this is a small anecdote from our initial days, where a US citizen whose mother was uh, being transferred to Beach Candy from Malabar Hills was following the ambulance in a black S-Class Mercedes. She actually refused to pay, saying that in the US, this service is not charged. We said, I mean, we cannot not charge someone who's following in a Mercedes and refusing to pay 500,000 rupees at that time. So at times we have to put a foot down, but we try to be as accommodating as possible while taking a decision whether to charge or not charge. So getting back to this, so this is how the cross-subsidy model works, and this is how we decide to charge or not. So it's worked beautifully for us, and we've seen the poorest of poor always being able to find money at the time of emergency to pay. While while a growth from 1 to 70 ambulance was happening, another sector had opened up in India, which is a public-private partnership where the National Rural Health Mission, at that time it was called NRHM, had decided to roll out ambulances across India, going state by state. So they reached out to all the players and said that they would want to get into a public-private partnership with us and try to reach out to as many people by putting the ambulances state-wise. So the first tender which had actually come out for this was in Bihar for 10 ambulances for the city of Patna, which we had won. And this was followed by a series of tenders for 108 across India. And as we speak, most of the states in India have 108 ambulances. Another development which had happened was 102, which is actually the mother-child transport system, also known as JSSK in Hindi, also rolled out sometime in 2013. So that service is used not more for emergency, but more for taking care of pregnant and newborn babies right after delivery, and to incentivize the mothers to deliver in the hospital rather than using the midwives and delivering at home. This has actually helped in bringing down the mortality rate a lot. So this is how we have evolved from the private model. We've got into the PPP model, and we are working on both the sectors also as we speak. About a year and a half, 2 years back, we decided to at least explore opportunities of going into international markets. The first opportunity we got was in Dubai, when a lot of people who were being trained here and were going to Dubai were actually ex-employees of Ziqitza. So the Dubai government actually reached out to us and asked if your trainings, sending so many people from here, ex-employees and all that, why don't you actually come and run the service for us? So we actually tied up, and we've got about 10 ambulances in Dubai right now. And we have won a few tenders also. The Al Maktoum Airport, which is coming up in Dubai, in UAE, we won that. We won the tender for setting up ambulances there on a tender, and there are many more such contracts that we're looking to tap and grow in Dubai. So if you look at the UAE market and the GCC market, that market by itself would be as big as all the 30 states of India combined. So there's a lot of potential there. Besides that, there's potential in Southeast Asia, Africa, and we are quite ambitious and look forward to growing strongly in those areas also. I would say very, very important. So what I mean is when you go into the rural areas, forget about finding bad roads. A lot of places you don't find roads also. So you have to go through the muddy areas, navigate, and get to the particular location where the ambulance call was made from. So roads are very important. Second bit is uh, over the last few years with the boom of GPS and all ambulances are connected by GPS and are controlled from the call center in terms of their movements and all. In the rural areas and a lot of the urban areas also, network is a big problem, because of which we lose connectivity with the ambulance, and which causes us to lose valuable time in trying to navigate the ambulance to get to the location. So that is the second big bottleneck. Third infrastructure issue is the manpower. I mean, it's not exactly infrastructure, but there aren't enough skilled people to man the ambulances. So any contract which we get into, we have to actually get people trained and man our ambulances. So it's not like it's a market where we can go and pick up the staff from. So that is the third big important issue. Fourth, which is again not infrastructure but a related item, is the awareness and education of the people across the country. Just to compare again with the US or the West, children are taught what to do in case of an emergency. They know basic things like first aid, they know CPR, and that is the difference between saving a person's life and losing him. There's a concept of a golden hour and a platinum 10 minutes. If you get to the patient in the golden hour and treat him, chances of surviving increase. If you get to the patient in the platinum 10 minutes, the chances increase much more. It is quite unlikely that you will get to the patient in the platinum 10 minutes. So the next best thing is for the patient's relative or his nearby to take care of the patient and at least stabilize him to the extent of maybe if required give CPR, lay him down in the proper position. And that could be the difference between life and death. So this awareness is not there. So this is something that which cannot be taught to people in our age group. It has to be taught when the at the child level in schools and all. It should be made a part of the syllabus of school children. So in India, we have recently won a tender in Madhya Pradesh and Jharkhand. Our concentration right now is to roll those services out ASAP. We are also looking at other tenders as and when they come, and so we have been bidding in all the state contracts which come, whether it's for 108 or for 102 or for the helplines. We have a private arm which I mentioned to you. Which we started with, which was the 1298 helpline, 1298 services which we provide, in which it's a pay-per-use model, in which we send the ambulances depending on the calls we get, and we charge to the patient based on the call, based on the kilometers. We are looking at expanding that. Another model which we have is we have a lot of corporates and hospitals which want to outsource the ambulance services to outside agencies, and we are one of the leading players in getting these contracts. So we have a lot of big hospitals, lot of corporates who just want to issue a paycheck and not worry about running, taking care of the driver, taking care of the EMTs, taking care of the R&M. So that is one area also which we want to expand in. And fourthly, and as I mentioned earlier, one of our most ambitious forays would be to expand the international sector. So Dubai, we're already in. We expect to grow in the United Arab Emirates, the GCC, and look at further forays into the African markets and Southeast Asia. I think this is a recession-proof industry. In fact, when the economies are down, people get more heart attacks and we get more business. I mean, jokes apart, but there's a lot of potential for growth because if I go by statistics, we are supposed to, the NRHM guidelines say that they should have one ambulance per 100,000 people. So that guideline is actually being changed to one ambulance per 60,000 people. So that would mean about almost doubling the number of ambulances which are required in the existing states. Moreover, there are a lot of states which still don't have the services, which will at some point get the service, and that would be a market which would be available to all the players, including us, to go and tap. Besides this, I mentioned 102, which is the mother-child transport system. That is something which is still at a nascent stage. That is also growing. That would also require a lot of ambulances to be put on the road. And internationally, you have the same markets which I mentioned, the whole of GCC to capture Southeast Asia, South Asia, Africa, which are still underdeveloped in the ambulance space. So one more thing is, like, countries like Dubai and all have ambulance services, but they want to outsource it to an agency, which India is already doing. So which would mean that they would look at operators like us to come and run the services for them. So there is competition from 2 or 3 big players, and all the in all the tenders we have the same 3, 4, 5 players coming and bidding. And so we win some, we lose some. So there's good competition. There's good, healthy competition from the other players. And once we win a state, then it is working with the government. There's no competition. It is just about providing the service and all that. The competition is only at the tender stage. So MP as a state has evolved. They have been running the service over the last 6, 7 years. One of the changes that they have made in the model compared to other states is that they have integrated all the services into one platform run by one operator. So you have the 108 service, which is the emergency service, the 102 JSSK service, the 104, which is the helpline for medical services, and MMU, all integrated and run by us as one operator. And all these services are available in one number, 108. I had mentioned how difficult it is to remember different numbers. Now, instead of remembering 108, 102, 104, they just have to remember 108. Even now, as we speak, we're running 108 and 102 parallelly in one state, Orissa. A lot of calls which we get for 102 are actually supposed to be 108 calls and vice versa. So now it is for us to quickly transfer the call to the correct department. So I think it'll make things much easier for the public.